Hello everyone, welcome back. Today I'll be covering avascular necrosis of the hip, a part 1 video. Started off with an introduction. The risk factor for avascular necrosis include 1. Medication and drugs, A. Glucocorticoid, B. Biphosphanates and other anti-resorptive agents, 2. Alcohol, 3. Cigarette smoking, 4. Post-transplantation, 5. Systemic lupus erythematous SLE, 6. Trauma, 7. Genetic disorder, include A. Sickle cell hemoglobinopathies, B. Gaucher's disease, 8. Radiation therapy, 9. Decompression disease. Now, let's get started. As an introduction, osteonecrosis, also known as aseptic necrosis, avascular necrosis, AVN, atraumatic necrosis, and ischemic necrosis. There is reduced perfusion leading to ischemia and eventual death of the bone and marrow cells, bone marrow infarction, and ultimate mechanical failure among the proposed etiologies. The process is most often progressive, resulting in joint destruction within a few months to years. The femoral head is the most commonly affected, but it can occur in distal femur, humeral head, scaphoid, talus, and other small bone of hand and foot. The risk factor for avascular necrosis include A. Medication and drugs. Number 1. Glucocorticoids. The risk range from 21% to 37%, but depends on the frequency, duration, dose, and associated comorbidities. Pathogenesis involved include alteration in circulating lipids with resultant microemboli in the arteries supplying the bone. Another, increase in the bone marrow adipocyte size and number within the bone marrow compartment contributes to blocking the venous outflow, resulting in increased intraosseous pressure. Another theory proposed that glucocorticoids induce changes in venous endothelial cells, leading to stasis, increased intraosseous pressure, and eventual necrosis. The initial glucocorticoid dose is most important than the total dose or duration of therapy. A meta-analysis of 7 studies shows dose-dependent association between the glucocorticosteroid use and avascular necrosis. Each 10 mg per day increase in glucocorticoid dose was associated with 3.6% increase in the risk of avascular necrosis, and dose more than 20 mg per day resulted in higher incidence. Another study showed that higher dose in the first 1, 3, and 6 months of glucocorticosteroid therapy has higher risk of avascular necrosis. Medication. Number 2, biphosphanates and other resorptive agents. The use of, particularly in patients with malignant disease such as multiple myeloma and metastatic breast cancer, is a risk factor for osteonecrosis of the jaw. This disorder has been likened to a radiation-induced osteonecrosis of the jaw and presents with non-healing of the socket following a tooth extraction or exposure of the jawbone. Other anti-resorptive agents, example denosumab, can also induce osteonecrosis of the jaw. Number 2, alcohol and avascular necrosis. An elevated risk for regular drinkers and a clear dose-response relationship were noted. A relative risk was 3.3, 9.8 and 17.9 for consumers of less than 400 ml per week, 400 to 1000 ml per week, and more than 1000 ml per week of alcohol compared with a control subject. Number 3, cigarette smoking. It has been implicated as one of the risk factors. However, it is difficult to assess the true risk of tobacco use due to associated with and the potential confounding effect of alcohol intake. Number 4, post-transplantation and osteonecrosis. Around 5 to 20% of renal transplanted patients, with 50 to 70% of affected patients having more than one joint involved. However, a decreased risk of osteonecrosis in renal transplanted patients following the usage of cyclosporine and tacrolimus with consequent decrease in glucocorticoid dosing. Osteonecrosis may occur with other types of transplantation. Example, hematopoietic cell transplantation (HCT). It depends on the sex of donor and the recipient, as well as the disease for which the HCT is performed. Number 5, systemic lupus erythematous (SLE). Osteonecrosis has been reported in 3 to 44% in patients with SLE. Patients with SLE who have taken glucocorticoids are at greatest risk, although certain cases have been noted in the absence of this therapy. In regular dose of prednisolone greater than 20 mg per day, evidence of glucocorticoid associated and organ effect, Raynaud's phenomenon, and hyperlipidemia are risks for developing osteonecrosis. Additional associations have been suggested, including the presence of antiphospholipid antibodies, but is controversial, Cushingoid habitus, vasculitis, neuritis, and CNS central nervous system involvement. Number 6, trauma. Fracture or dislocation may cause damage to the extraosseous blood vessels supplying the affected region. Anatomic sites that predispose adjacent bone to avascular necrosis after fracture include the femoral neck, proximal humerus, talar neck, scaphoid, and lunate. Number 7, genetic disorder include A. Sickle cell hemoglobinopathies. Osteonecrosis is common in patients with homozygous sickle cell disease due to various mechanisms, including red blood sickling and bone marrow hyperplasia. The prevalence around 10 to 50%. B. In Gaucher's disease, it is a hereditary autosomal recessive disorder of glucocerebrosidase metabolism which results in the accumulation of cerebrocyte-filled cells within the bone marrow. This process leads to compression of the vasculature and to subsequent osteonecrosis. Number 8, radiation therapy. Osteonecrosis may result from external beam radiation therapy, osteoradionecrosis. Osteoradionecrosis of the mandible may be complication of treatment of head and neck cancer. Number 9, decompression disease, also known as dyspareunism and caisson disease. The increased pressure leads to the formation of nitrogen bubbles that can occlude arterioles and cause osteonecrosis. Symptomatic osteonecrosis can develop years after the exposure. The number of exposures and the magnitude of depth and pressure are important risk factors for caisson disease. Yay! We have reached to the end of this video. I hope it helps. See you in the next one. Take care and bye.